can see some thumbs up, so that's great. So thank you very much for that introduction, Lucy, and it's a delight to be here today to kind of maybe conclude or not conclude your series of sessions around meaningful patient and public involvement and engagement. So today I'm really going to focus on this sort of practicalities of patient and public involvement and engagement to hopefully take all of that inspiration and passion that you now have after the first two sessions and help you actually understand how you would actually go out and maybe do it in your own work and deliver it in your own contexts. So by the end of the session today, I'm hoping that you guys will understand a little bit more about where patients, carers and the public can add value to your work if you weren't already convinced by everything else you've seen so far. I'm then going to take you a little bit through about understanding the theory behind patient and public involvement, and which will help you learn how to develop your own involvement ideas, and then also give you some practical hints and tips that will equip you when you actually go into planning, delivering and designing your own activities, so that you won't fall into some of the common pitfalls that do trip people up. Now, obviously, I'm going to go through my slides, but if you have any questions, please do put them in the chat. I can see them. So if they are things that come up in the session or things that kind of like are related, I can draw them in. And if not, obviously there will definitely be time for some questions at the end of the session as well. So the first thing I kind of wanted to start on is with a bit of a definition. I know definitions are not most fun or dynamic things to start with, but I just wanted to take some time to make sure that when I'm talking about patient and public involvement and engagement today, we're all on the same page as to like exactly what that means. So patient and public involvement and engagement, sometimes shortened to PPIE, sometimes also shortened to PPI. I will probably slip between all three of those depending on where my mind is at the time. It basically describes all the different ways that patients, carers and members of the public can work with us on health and care projects and programs to help us inform the outcomes. So the key thing to take away there is this idea of with. It's not a passive process, it's an active process. It should be about two-way interaction. So it's this idea of talking and listening and engaging with one another in a kind of dialogue. Ultimately, what PPIE is all about is it actually shares, it recognises that patients, carers and the public are protagonists in health and care. And what we're saying is actually that they have really, really valuable lived experience that we need to hear about and actually need to take into consideration when we are doing and designing projects and programs in health and care. Because otherwise what happens in what is happening quite commonly now is that yes, there's loads of learned experience from the research and from the NHS, but we kind of go away and we'll design stuff, but it may not actually realistically reflect the reality, the lived experience, the actual situations. And that means that actually it doesn't have the real world implications and impacts that we want. So we want to make sure that actually the things we do better reflect the real world, are able to be implemented a little bit better, help support people learn a little bit better. So that's why it's really, really important for us to do patient and public involvement and engagement. So the main bulk of this session is really going to take you through this idea of how you plan and do patient and public involvement and engagement. Now, the first thing I kind of want to start is a little bit of a caveat to say that actually there is no one size fits all approach to patient and public involvement and engagement. So I'm not going to sit here today and give you be able to say, oh, well, if you really want to engage with old age people, this is how you do it. Because unfortunately, that is not the way it works. So what I will be talking to you guys is about the theory and the thinking, and this theory and thinking will help you understand how to develop the patient and public involvement engagement approach that will actually fit what you want to do and your particular context. So there are 3 steps to excellent involvement, and if there is only one thing you take away from today, I hope it's like these 3 steps. So the first step is this idea of why. So what is your purpose? Why are you wanting to do patient and public involvement? The best involvement projects have a really clear defined purpose right from the start. So to get yourself to the position where you actually know what your purpose is, you should ask yourself 3 core questions. So spend some time thinking about how involvement engagement can add value to your work. So ultimately, what is it you want to happen to your work as a consequence of involving patients and carers and members of the public? Is it that you want to get more realistic simulations? Is it that you want to be able to actually shape healthcare pathways through doing a simulated practice? Is it that you really want to have new stories to tell? All of these are really valid things to want to do, but obviously you need to kind of think about that and define that right from the start. Equally, you should take some time to think about what you want to get out of this involvement. So involvement is great because it gives you lots of different opportunities and different ways of working, and it can really enhance and build your own skills. So what do you want to take away? Do you want to have new relationships with community organisations? Do you want to learn how to communicate a little bit differently? Think about it from that perspective. Also, then the third thing to think about is what it is you want your contributors to take away from this experience and this project. So, as I said, this is all about like dialogue and sharing and reciprocal relationships. So you want there to be a mutual benefit. So it's not all about taking things away from your contributors and then kind of disappearing into the ether and they never get anything out of it. You want to share. So think about what it is that they might be able to get out of it. So is it giving them new skills and experiences, giving them a new understanding, helping them to feel valued and that they are part of the health and care process? These are really, really valuable things that loads and loads of contributors are crying out to do. So make sure they can have the opportunity to. So once you've got your purpose and your overarching sort of vision for what you're trying to achieve, you can actually then convert this purpose into your specific aims that will sit underneath it. So your specific aims are three things, and I would say no more than 3, because if you go beyond 3, it gets a little bit muddy and weird. They're the 3 things that you have to specifically do to actually achieve your overarching purpose. So your aims could be things like, so I want to be able to engage with patients, to be able to create a more realistic simulation. I want to then share that story, etc. So when you are designing yourself some aims, obviously think about it in a smart way. So make sure that you are being very specific in your aims. Make sure that you're making them measurable so that actually you can show that you are achieving what you're setting out to do. Make sure they're achievable and realistic. In all honesty, if you think that by doing one patient involvement activity, you are going to change the face of teaching and education, that's not realistic, I'm afraid. So scale down your ambitions, be really sort of like, what is in your realm? What is it that you can actually achieve in that time? What is within your scope? And also think about making sure everything is time bound, because you want to have a specific start point and where you're going to be engaging with patients, and also a specific end point of where you might be not walking away, but ceasing that sort of project, wrapping it up and being able to share that learning and share the outcomes with those patient groups. So the next step to creating yourself an excellent involvement project is defining your who. So who are the people that you need to contribute and have in the room working with you to actually achieve your vision? So the first thing to say about thinking about your audiences and who you want to engage with is this idea of not clustering people. Don't fall into like this pitfall that some people do, that they just say, oh well, I generally want to engage with patients, or I generally want to engage with the public or the general public. These are words that we absolutely hate in patient involvement and engagement. So just avoid them, because the public and patients, they're not one giant homogenous group. There are really distinct clusters of people, and what you want to do is work with distinct clusters of people, because those distinct groups of people have different viewpoints or different experiences, and depending on what you're trying to achieve, that kind of says who you need to talk to in that instance. So on this slide, I've put some examples of the common ways people might group and cluster people to help them actually shape what they're doing. Because we would say it's more important for you to have a meaningful engagement with smaller groups of people than doing an activity that you talk to hundreds of people and you have really shallow conversations that don't allow you to actually evolve your practice or change anything or shape anything. Because ultimately, that's a waste of your time, and that's a waste of patient and contributors' time, because you're not actually having any meaningful interaction there. So think about your significance over your reach. So some ways you might think about grouping people is around their lived experiences of specific conditions. So that might very well be actually people who have the conditions themselves, or it could be families and friends, or it could be formal or informal carers. All of these people have really different insights and perspective to the health and care journey, and depending on what you're trying to do, they might bring the different insights to the table. You could also be looking at engaging with people who are at risk of certain conditions. So actually it's that they don't have a condition now, but they might be a community that has a higher incidence later in life. So say heart disease. So you may want to engage with them. Equally, it could be about engaging with people who use certain health and social care services, or the people who should be using those services but actually aren't. It could be thinking about engaging with people who are targeted by specific public health initiatives. So if you think about recently, there's obviously been a lot of like the COVID community buses. That's a specific a specific public health initiative. So it could be working with communities like that. Equally, you might want to take a little bit of a broader sphere in the terms of looking at to engage with organisations or charities or community organisations who represent particular service users or people with specific lived conditions, because they obviously have a lot of experience working in those groups or working with those people, and can add a different sort of flavour, a different perspective. Or very classical ones is thinking about geographies, locations, and people who have certain demographic characteristics. Now you can just focus on like grouping people with one of these things. So you could be like, okay, I want to do a project that I'm engaging with people who have asthma. Or you could be even more specific by tying some of these things together. So you could say, I'm really interested in speaking to people who have asthma and live within the ULEZ zone and are between the ages of 25 and 35. Now that sounds really, really niche, but actually, if that is the sort of people who are going to help you achieve your aims, then it's better to have that nicheness, and that so that you can bring those people into the room and have those meaningful conversations and that dialogue. So just to reiterate that point, I've got it on a slide. So as I said, who you need to have in the room, think about it, go back to your aims. That will actually tell you who it is that needs to be in the room. When you've got that definition of who needs to be who you need to work with, who needs to be your contributors, think about what do you actually know about these people already. So obviously, just from your day-to-day lives and interactions, you probably know things about certain groups. So you know things about parents in terms of like their day-to-day habits, in terms of they're dropping off their kids, they're picking up their kids, they're going to have kids, so they might need to do an activity that entertains children, or you might need to provide some options on how to for them to be able to get babysitters, etc. That helps you kind of think about the things that you might need to do or shape your activity for. Equally, what is it that you don't know? What is it that you need to find out? Like, it's all well and good that I'm not expecting everybody to know everything about every single group out there, but it's better off to be able to say, actually, I don't know a lot about the experiences of people with a stroke and how to work with them. So who does know that? Who can I go and talk to that might actually have a bit of insight, a bit of experience in working with people with experience of, say, as I said, stroke, and then learn how to design something that will actually support their involvement and their attendance. And also by thinking about, who it is that you need in the room, you're also able to start thinking about where might these people be? Where is it that they hang out? Where do I need to shout, or where do I need to go and talk or position myself to actually reach out and engage these people in the first place? So I've got a nice little handy list of potential places that you might want to go when you're thinking about engaging with people, wanting to reach out to engage with people and involve people. Now, obviously, in the medical sphere, whenever I talk about this, people immediately go, oh, well, I can go into like clinics or surgeries. And I know actually that's not the reality for quite a lot of the medical profession. Also, because when you think about if you go into clinics and surgeries and you put things up on the wall or notices, only the people who are really, really already involved in their healthcare are going to see those things. So actually, if you want to work with a group who potentially, avoid going to, say, the pharmacy or going to their GP, then that's not the best space to advertise in, right? Like, you're going to completely miss them. So there are lots of other places that you may want to go to find people. So there are lots and lots of community organisations out there. So this might be community organisations who support or represent people with specific lived conditions. So say, as I say, people that have experience of stroke. Or it could be local community groups such as like residents associations or mums and baby group, or something completely different. There are loads and loads of different organisations out there, and lots of those people are willing to be involved in activities that might shape their and support their future care, because a lot of these communities do really care and are really passionate about their health. It's just that they're not necessarily reached out to in the right way. There's also Healthwatch. So Healthwatch is a local government association, I think, and they actually their entire sort of purpose is that they want health and social care to be civic and be led by the citizens. So they are really, really happy to support activities that actually show that value. So reach out to them. There's also local and national charities who already have like communities of people with lived experience. So you could reach out to those groups. Alternatively, there are some websites that you can go and advertise. So there is the Patients in Research website and the NHS Get Involved website, which basically you can post virtual notices to say, hey, we're looking for some people, come and join in. It can be really useful. Again, caveat of that is that it's people who already know about those websites. So it's likely to be patients who are really, really engaged in health and care. So do think about that when you're thinking about whether they're the right people. Local authority public health teams, again, they normally have newsletters that they're happy to advertise in and send things out. Don't forget the power of social media and also the power of word of mouth. If you have some friends and family who are in groups, get them to share it for you. It really, really works. And yeah, and thinking about what communities exist on social media that you could tap into and ask them to like share and spread the word on your behalf. Also, shameless plug for existing patient and public involvement engagement teams. Lots of NHS trusts have engagement teams or patient experience teams who have lists that they can potentially put advertisements in out to as well. So do just reach out to us. Lucy, your hand is up.
Yeah, no, am I right in saying that if you're in North Central or East London, we would be able to put you in touch with PPIE groups, and it's worth asking anyway, because Nat, you might know those in West and South.
Yeah, indeed. Yeah, so we are here to facilitate that sort of thing. So yeah, northeast, north central, and mid and south Essex, we have sort of connections with. But beyond that, yeah, if there are other spaces that you want to reach out to, do just let us know, because yeah, we do have quite good links with HIN and Imperial College Health Partnerships. So let us know. We all talk, basically. All of the patient and public involvement people talk to each other and have our own little network. So just reach out to whichever one of us and we can help you as much as possible in those spheres. So obviously I've told you where you can go and find people, and you're like, great, so I know where to go, but like, how do I even have those conversations? What do I say? Oh, I've got a slide for that. So how do you go about onboarding people? And realistically, it's about being a person and having a conversation and having a chat. So one of the cool things to do is have a conversation to build relationships. So offer, if you're doing like cold calling emails, being like, I'd really like to get, say, a community organisation on board, give them the opportunity to come and have a chat with you one-to-one so that you can actually meet each other, ask questions, etc. And when you're having the conversations to try and onboard people, like either on a one-to-one basis or on a community group, think about what you're doing. So telling people what you're doing and why you're doing it. So why it's so important, what you're hoping it's going to achieve, what you're hoping it's going to change, and then why you want patients involved or these contributors involved. Like being able to acknowledge and say to people honestly that we know stuff, but we don't know everything, and we really value the insight, and we need to make a change, and this is how we make change. And a lot of people, you know, really appreciate that you're showing them that you value their time and their expertise and their knowledge in this situation. Ultimately, you might, you know, reach out to a community organisation and they say, yep, that's great, we'd be happy to advertise, send us something to go in our newsletter. We're like, oh God, how do I write an advert? I've got a handy paragraph on how you write an advert. So the thing to keep in mind when you're writing an advert for any sort of patient and public involvement engagement activity is keep it short and sweet. People do not like blocks and blocks of text. Like the amount of times people send me over like an entire A4 page that's just a wall of text, and I'm like, people won't read that. People aren't interested in that level. People very much just want to get to the point of, who is it you're looking for? So being really upfront. So I'm looking for people from XYZ and that have a lived experience of such and such. What is it you're looking to do? So ultimately, what is that ambition? What is your purpose? How are you going to do it? So what's the activity going to look like? Are we talking that it's going to be a one-off thing? Is it going to be a long-term sustained project? When and where it's going to take place? So is there a specific time and day that I need to be available for this? Is it online? Is it in person? Especially thinking, you know, in the COVID world, a lot of people, there are certain groups who are still shielding or are very nervous to do things in person. So it's really, really important that you have that sort of information up front for them. Will people get reimbursed for their time? Now, this is something that I will come on to a little bit later about the importance of patient payment. But what I would say is that at the very bare minimum, you should be offering reimbursement for people's expenses when they get involved with you. So making sure that they're not out of pocket. But best practice now is saying that you should pay patients for their time as well. Now, the reason for this is that you want to show people that you value them as much as the people with learned experience, and those with learned experience, they're probably paid to that, you know, they're in roles and they're paid, and when you consult with them, their time is covered by their role, and so they're getting paid. Whereas what we're ultimately in a lot of situations, that's not the same for your contributors, and actually that feels really unfair, and it's not really showing people that I value you to the same standard as I value other people. Also, what happens is if you don't offer people payment for their time, you're only going to be able to hear from certain voices. You're only going to be able to hear from people who have the sort of like spare time or spare money to be able to come along to these things, so that they so basically the ones who are in a position to be altruistic volunteers. And you don't want that, because what happens there is if you only hear from those voices, we get really, really skewed demographics. You're not hearing from communities who are potentially impacted a lot by health inequalities, and that is, you know, something we really, really want to avoid. So do make sure, if you can, putting in some sort of cover for reimbursement and making sure that's up front in the advert. And then a go here. So an action for the people who have read that advert. of who they email if they've got questions or want to sign up, or a web page that might have an FAQ that if they're interested. So ultimately, what you're doing in that advert is being really short, sweet, no jargon, straightforward, plain and simple English in a couple of 200 words ish. Get all that information in there. A person can read that and go, tell you what, that's me. They can then go forward and find out more information and sign up. And if you stick to that formula, that is the way you're going to write winning adverts, and that's the way you're going to get people on board. So the final step is this how. So actually, this is where you start thinking about designing an activity. Now, for a lot of people, that feels really counterintuitive that the activity kind of comes last. And the reason for that is that actually, if you start with an activity, you're then going to start wedging in, well, why are you doing it, and who needs to be in the room to kind of suit the activity design, rather than actually thinking about, well, what am I trying to achieve? Who is it? Oh, so then I can design an activity that actually leads me to achieve what I want and actually suits the people that are going to be in that space. So it makes sense, but a lot of people start the other way around. But please don't. Follow this process, follow the why, the who, and then onto this how. So where could there be opportunities in a project or a program? So I've just mapped out like a basic flow chart here of the typical steps that come up in projects and programs right across the board. So the idea of like identifying and prioritizing and setting programs up, designing them, then doing like the undertaking and facilitation, the evaluation process, and then sharing the results or talking to people about it. So in there's quite a lot of different steps, and the thing to take away is actually patient involvement can happen pretty much everywhere in there. Patient involvement you should just look at where there is opportunity for patients to be able to actively shape and influence what is happening as a result of their involvement. So if you go back to the previous slide, if you are very much like you are in a position that you can't do some identification and prioritizing, so say you are working in a very particular set curricula, and so there is nothing that a patient can do to influence that, then don't involve a patient at that step, because pointless. Like, you're going to have a conversation, it's going to mean nothing. Involve the patient in a step where they can actually have an influence. So is it on the designing materials and how things are delivered? If yes, they can have an influence there, that's where you want to put patients. You can involve people in multiple places or just one. So just think about going back to that ambition of what it is you want to achieve. Is it something that it will just be a one-off? Is it that very much you just want to hear from patients around that they've gone through a simulation and you want to hear their feedback on how this new healthcare pathway works for them? That's fine. That's a one-off. That's done. Dandy, great. But you might want to work with them in a little bit more of a sustained way. So it could be that you want them to co-design a simulation with you and then co-deliver that simulation and be part of the evaluation and feedback to students who are learning and actually using that simulation. There you go. You're working with them a bit more longer term. But again, it comes back to what you're trying to achieve. So be proportionate with your aims, and also think about your resources. If you're in a position that you are not very well resourced and it's going to be quite difficult to work with people over a long period of time, don't do it, in all honesty. Like, just think about it being realistic. It is better to kind of like scale down your activity and do something that is maybe one-off or a little bit more manageable, rather than promising the world and then getting loads of patients, getting a couple of patients on board, and then a few weeks into it being like, oh, you know what, we don't have the time anymore. Because all that does is damage relationships. So actually, sometimes it's okay to be like, you know what, I have these lofty ambitions, but we're not there yet. So we're going to start off with something a little bit smaller, and maybe one day we will reach that. So I have put together this slide very much to give a very snapshot view of potential different ways patient and public involvement engagement could look in teaching and education and in simulation. For those who joined us last week, not last week, a couple of weeks ago, those were really amazing examples of what actually the diversity of patient and public involvement in simulation could look like. And if you weren't there, I implore you to go back and watch the videos, because it boggled my mind. I was like, oh my God, I've never even thought about a lot of these. But you know, that's what I'm saying about the fact that the activity can be so diverse. It just really comes down to what you're trying to achieve and who you need in the room to do that. So it could be that you want patients to be involved in designing simulations and working with you on that. You could have patients co-delivering training courses. So I definitely have patients co-delivering some of my training, which is great. It brings a completely different dynamic to the situation. And it's really, really valuable, because I learn a lot of stuff from having patients as co-deliverers. And I think a lot of my trainees do as well. You could have things like having patients become mentors. So when I worked at Queen Mary, we actually set up a patient mentoring scheme, and patients mentored some of the medical students for like a couple of years. And it was such a really amazing experience. The patients said about how much it empowered them, and it made them feel that the new generation of doctors were going to look at patient care a little bit differently, and they felt that it humanized the entire process of medicine for them. And the new trainee doctors were really enthused that they had a different opportunity to actually hear from patients, not on a one-off basis, but actually understand a lot more about like how their treatment and their care worked over a long period of time, and changed the power dynamics. So really meaningful opportunities there. You could have patients facilitating or supporting feedback sessions. So you could have them sort of like maybe training the actors that you might use, those sorts of things. You could have patients working with you to write blogs or articles about the work. So sharing why simulation is so important and the role patients can play in simulation. Or, you know, even higher up, or, you know, lofty ambitions, having patients working to prioritize curricula, be able to say, you know what, you're teaching that, but that in my experience of epilepsy, that really rarely happens. These are the things that regularly happen for people with epilepsy, and yet they're not the things that are taught. So why aren't they taught? So when you get to the point of thinking about designing your activity, there's kind of like four kind of main ways we say you can engage with people and get people involved. So go back to your aim and just take a look at what you're trying to achieve, and then think about what it is, the sort of activity that will support that. So are you thinking about doing something that's more about consulting with people? So consulting with people really focuses on this idea of asking for public feedback to inform and shape something. So it's a little more passive. In those situations, as I said, it might very well be that you get patients together to go through a new healthcare pathway, a new simulated healthcare pathway, and give their feedback about things that did or didn't work for you to be able to change it. The next approach is this idea of involving. So involving is a little bit more active. It's a little bit more sort of like two-way and engaging, and as the name would imply, involved. So that one is very much about working with patients to understand perspectives and consider alternatives together. So in that, you would potentially do that sort of consulting aspect of what did work, what didn't work. How could we change this? Asking patients actively, how could we change this? What might that look like? And trying to design that together. Collaborating is about working in partnership over a longer period of time around the decision making and outcome generation. So collaborating is probably for when you're doing like more sustained patient involvement. So it's something you're doing over a longer period of time because you're wanting to bring people in at an earlier stage so they actually can shape and inform something right from the start. So instead of when you're doing involvement or collaborating, you're kind of bringing them on board after something has already been formed and then asking them to help shape it afterwards. In collaboration, you're probably working with them like a little bit earlier into that process so that they're more actively involved. Then the final one is this idea of co-creation. Now, co-creation is like basically collaboration plus. Co-creation is basically working together from the start in a very, very democratic way where patients are given quite a lot of power. And so they basically, in situations of co-creation, a lot of the times you kind of go into a space and go, you know what, we're working on a subject matter, we're working on, I'm just trying to think of a subject matter that's not the typical ones off the top of my head. Anyway, working on cancer. What's the things that we should be looking at in here? And then you can co-create from the start. So realistically, you aren't going to be in a position to do all of these things. So just go back to your aim and what is feasible and reasonable for you in your position, and think about what approach will suit. And ultimately, if you're not in the position to be able to collaborate or co-create, that's fine. Don't try and force it. Just go for a sort of like a consulting or involved approach, and be honest with your contributors of what can and can't be changed, what is in focus and what is the sorts of stuff you can work on together, and what's not the sorts of things you can work on together. Because that is the best way to have a relationship with people, is to be actually just be honest and say those things of what's in scope, what's in scope and what's not in scope. So the next bit of how to go away and design an activity comes down to that who. So thinking about those people that you have in the room and you want to work with. So taking some time to think about the sort of activities that might really appeal to them and might really work for them. So if you think about it, people that are older are more likely to be less technologically like savvy and less comfortable in using technological things. So do you really want to throw them into like this super techie sort of approach with like artificial intelligence and all of these sorts of things? And no, probably not, because it's not a comfortable space for them and it's not going to make them like engage and have the conversation. So actually you might want to do something a little more, you know, retro, like just having a chat and a conversation. So just start thinking a little bit about, you know, those dislikes and likes and the things that are actually going to stimulate the sort of exchange that you want. You can then also think a little bit about the, you know, the times and the days and the locations and the durations that are going to fit your particular group. So, you know, just thinking about that practicality of when you're of how you frame and design things. Because if you're going to do something that you're going to do in the middle of a working day, there are only certain people who are going to be free in the middle of the working day. Are they going to be the people that you want to hear from and engage with? Or are they not going to be the people you want to hear from and engage with? And if they're not, then you're going to have to do something in the evening. And I know it's uncomfortable to think, oh God, but that's outside my working hours. Well, yes, but that's outside their working hours. And so if you want to accommodate them, you have to think about being a little bit flexible. Also thinking very much about, as I said, whether it's going to be a one-shot activity or a long-term project. So if it is a one-shot activity, that's fine, that's enclosed. But if it's a long-term activity or project, you need to think a little bit about, you know, making sure there is that flexibility, that you're upfront about that the activities actually encourage people to be involved long-term, and is a reasonable commitment as well, that you're not expecting people to work with you for like long term, that it's going to be like, oh, you're going to have to take 5 days off work or whatever. That's not reasonable or feasible, really. So if you don't know a lot about your audience and you're like, oh, I don't know how to design an activity that's going to support them, ask. Go and ask your peers if they've had any experiences doing patient and public involvement or engagement with people, or just generally worked with communities in any way, shape or form. Ask them the sorts of things that worked or the things that they found out didn't work. You can reach out to charities and community groups that already work with these groups and say to them, how does stuff work? Like, what's the best way to do it? Going on to like, you know, onto websites, so thinking about like the British Heart Foundation, you can see how they pitch events and the times that they do events, and that can give you a really good steer on the sorts of things that might actually work for you with what you're doing. If you've already made contact with patients, and you know, you're saying, oh, we'd like to work together, you could always just say to them, you know what, how can we do this to make this the best that suits you and supports you? So at the moment at UCL Partners, we're creating a patient advisory group, and I pretty much have created a blank framework. And one of the first sessions we're going to do is sitting down together and say, well, how do you want to work together? How can I support you? What do you want things to look like? And actually, it's a really, really valuable way to make sure actually what you're doing supports people to get involved and gets the best out of it. Also, come and ask patient and public involvement colleagues. As I said, lots of NHS trusts have them, lots of hospitals have them, universities have us, we sit in other weird spheres like UCLP. We have experience of doing this, so you can come to us and we can tell you from our experience what things have worked and what things haven't worked to give you a little bit more of shaping. Ultimately, though, what I would say is it is a little bit of trial and error. You can design things and they may not go perfectly to plan straight away, but that's all right. That's kind of the beauty of patient and public involvement, is learning from it and reflecting on it, and yeah, being willing and open to change and be challenged as you go. So there are some things that I would say will really help you to design things that are actually accessible right from the start. And that's thinking about this idea of barriers to involvement. So thinking about what sort of things are things that typically could prevent people from working with you. So you can kind of break these down into two sort of strands of thinking. And so there's the practical things. So things like, you know, your times and your locations. So, you know, making sure, thinking about, oh, is a hospital setting really the best place for this activity? Are people really comfortable in this hospital setting? Or am I better off going into a community space, a church or something like that, and doing it there because actually that's more familiar? As I said, timings, like thinking about the right days and times that will actually appeal to people. So thinking, you know, if you're really wanting to do something with parents, school drop-off time, school pickup time, terrible times to potentially do that. So don't do activities there. Think about adapting it. Also thinking about the language that you use. So making sure that when you are like talking to people generally, that you use like plain, clear, accessible language that doesn't immediately kind of put up that us and them perception, by being like, oh, I'm using really complicated terminologies and I'm using lots of acronyms. It's really, really alienating. Also in language, of course, thinking about where we work. Across London, it's a very, very, very diverse community, and not everybody is going to be extremely confident with English as their first language. So thinking about what sort of adaptations you might need to do there, to encourage people to be involved, whether you might need translators, whether you actually, whether the communities you work with are probably more confident in spoken English versus written English. So you do things that are mainly about a dialogue rather than activities that require a lot of writing. Then also thinking about sort of the systemic things. So thinking about things like accessibility. So making sure that obviously people have access, making sure that if you're working with potentially communities who are blind or deaf, that you make sure that you accommodate that, making sure that if you're working with people with language, with special needs, you accommodate that, making sure that you give people the opportunity to bring their carers along, or if they're a carer, making sure that they actually can provide alternative care for whoever they're caring for during the time they get involved. Thinking about making sure there's access to equipment. don't presume everybody has all of the tools and softwares and things that they need. So lots of people make the mistake of thinking that everybody has Word on their computer. Lots of people don't. So thinking about if there are documents that you need people to be able to read or get involved with, making sure that you've got alternative formats for people to be able to access. If you're doing something that's online, making sure people have the opportunity to if they're in a household where they're reliant on mobile data, providing them access to mobile data, those sorts of things. It really, really helps make sure that people can actually get involved. Thinking about creating spaces where there isn't power dynamics. So if you think about it, automatically in health and care, there is this weird power dynamic where people with the learned experience have more power in these spaces versus the people who have lived experience. So how do you create something that balances that? So thinking about making sure that when you create activities, you're actually supporting patients to get involved. So saying things like facilitation, so that patients actually get the opportunity to speak, that it's not all about sort of like that one way, that there is that time where patients are speak unchallenged, unfiltered, whatever they need to say. Making sure that, as I said, the language is accessible, making sure that you're not just potentially plonking patients into spaces that are very sort of like medical associated. So lots of people just invite patients to come and sit on their boards, and it's like, well, our boards aren't designed to accommodate patients, because they're designed to be a little bit political, a little bit in equal powers. So that's going to be a really uncomfortable space. So how would you support someone? Well, it's, briefing chairs, making sure that chairs make sure that there's space for the patients to talk, you facilitating that patients, the things are deferred to for patients. There's an actual allotted space for a patient to be able to talk, that patients get pre-briefing if they really want to, the patients get the opportunity to actually maybe speak to the chair separately if they want to. All of those things to kind of unequal those power dynamics as much as possible, or equally, create a space together in a way with patients actually having the opportunity to shape things and be collaborative and co-create. That completely erases that power dynamic. And then also, as I said earlier, that idea of cost. So it is really, really important that you don't rely on people's goodwill. It's not about altruistic volunteering, that you should pay people for their involvement with you. As I said, at minimum, it should be reimbursement of their costs, so they're not out of pocket for things like transport, for carers, for the equipment that they might need, for printing, for postage. Cover all of those sorts of things by default. And if you can, and I would say probably look at your local policies about this, because some organisations have policies where you must pay patients, so be aware of that. Pay patients for their time. Now, the exact cost of what it will be for patients' time, unfortunately, I would love to say it's very straightforward across the board, that there is one payment rate for everything. Sadly, there is not. It varies quite a lot between organisations. It varies quite a lot between between organisations. It also varies a lot in whether you're working potentially on an NHS-based project versus, say, something that's been funded by the NIHR. Those have got two different payment rate guides as well. So it is a little bit confusing. So I would say just try and familiarise yourself with what is the local policy to you, to find out what the best approach is for that. So what are the sorts of things that you might be able to do to overcome and minimise barriers? Well, I mean, I've hopefully gone through some of these, but thinking about, making sure locations are welcome, familiar and accessible, making sure times and durations are also things that fit people's lives, clear and accessible language, and jargon-free. We hate jargon. Non-hierarchical spaces, time and expenses paid for, and providing any equipment that is essential. So, by taking yourself through that process, you now will hopefully have a wonderful sort of like, if you go away and think about that, you'll now have like a wonderful development idea that you could go out and do. Now, the one thing I would say is that, as I said, it's not it is a little bit experimental. You're not going to nail it the first time. So there is a little bit of a learning element. So I wanted to just take some time to talk to you a little bit about how you think about improving your patient and public involvement and engagement. And that comes down to doing evaluation. Yay, everyone's favorite thing. So evaluation is something that you should think about whilst you're planning your activity or your program, so that you actually have the opportunity to reflect and learn right from the get-go. And you're not doing this thing that lots of people do, that they forget that they should be evaluating, or they don't really think about the learning. And then they get to the end of their program and they suddenly go, oh yeah, so what worked well and what didn't work, and did we actually achieve what we set out? And then they're all like, oh no, and then they scrabble around and try and figure out how best to like work out what they've done from what they can remember and all this scattershot of data. So don't do that. Think about evaluation at the start to give yourself some space and time. So this is our little a little evaluation wheel. It comes from the Centre for Public Engagement evaluation toolkit from Queen Mary. It's a lovely toolkit. I worked on it. I would advise you to download. It's great. But basically, when you're looking at evaluation, there are 3 ways you can look at your evaluation. So you can evaluate the design of what you've done. So basically saying, is what I designed fit for purpose? Like, was it the right time, location? Did I have, like, was the language accessible? Was the activity pitched well? Did I have enough equipment? All of those sorts of things. It's a really, really straightforward way of like kind of evaluating your success and making sure that if you were to do a similar activity again, you adapt and change the things that didn't work so well. The next way you can evaluate things is kind of evaluating that delivery and outputs. So that's thinking very much about like, did I achieve what I said I was going to achieve? So if I said I wanted to design get a new simulation that was more realistic to the patient voice, did I get that? Did we achieve that? Well, by that you can then speak to the patients and say, hey, like, is it more realistic now? Is it more meaningful now? Does it actually is it the reality? All of those sorts of things. So it gives you an opportunity to say, oh yeah, I did what I said I wanted to do. Great, wonderful, tick. Then there's this third way of evaluating, which is a bit of a longer term evaluation, which is about the impact. So this probably goes a little bit more towards evaluating like your purpose, that like golden standard overarching vision for what you're doing, which is like kind of maybe the longer term change you're hoping that your activity will do. So maybe you were hoping that as a result of having a new simulation, it would make sure that it would change the teaching, and the people you're teaching would be better equipped to deal with real life situations. Well, you're not going to be able to see that right away after they've done like the simulation. That's something that will come out like 6 months later, after potentially they've been in these situations, and they can say, you know what, that simulation really, really helped me. So that's kind of like this longer term evaluation piece that you might want to do. So just a quick sort of like overview on how you think about doing your evaluation and get it embedded into what you do. Just go back to your aims and say, well, what are my aims? What might success look like for each of those aims? So what is it I'm hoping to achieve? What would make me go, tick, I've done it? What sort of indicators might you need to actually be able to say that I achieved it? Well, is it simply that, that everyone said, oh yeah, I gave it, like, it was great, I had a great time and it really helped me? Yeah, that's fine. That's like an indicator to say that, yeah, you achieved it. If you're saying, oh, I wanted people to enjoy it or whatever? Or is it that sort of piece around oh, I want people to have more knowledge. Well, how would you measure if they have more knowledge? Well, you'll need something at potentially the beginning and the end that shows that their knowledge has changed, like a quiz. If you were to do something like that, like if you didn't think about that at the start, like how would you create that after the fact? You wouldn't have anything to evidence that. And so then you can think about what sort of tools might help you capture that. And the best way to think about this is like, how can you integrate any evaluation you're doing into your actual activity? So making it feel like it's part of the process. So it could very well be just asking a question at the end of, say, a focus group to say, like, was this valuable for you? Or do you now think that simulation, like, do you now understand a little bit more about the role simulation plays? Something like that. Like, it doesn't have to be really complicated evaluation, but just give yourself a little bit of time to reflect on what you're doing and be able to learn from it as to whether you're achieving what you're doing and whether the things in future, if you do an activity, whether you need to change something. Another thing to really think about is this idea of you said and then we did. So quite commonly, people will, engage with patients and then they will go off and do something as a result, but then they won't tell the patients that as a result of their involvement or their contribution, such and such has changed. And what happens there is patients are like, well, what was the point of me being there? Like, I haven't seen any change, or I don't know what's happened. And that really, really damages like that relationship. And it means that patients become a little bit less likely to be involved in future. So just take some time to actually inform and loop people in and keep them updated. So just think about what, going back to asking patients how they'd like to be kept in touch with, and then giving them a bit of an update a little bit later down the line. So saying to them, well, what did you tell me? What did you say? And then what happened because of the things that you said? Like, what did we change? What was the consequence of the feedback you gave us during our activity? What did you shape? And equally, what didn't change and why couldn't that be changed? Just being open and honest to be able to say, we know you all said that when we were doing this simulated healthcare pathway, you all said that it was rubbish that you had to come back and chase up like 3 days later for the results or whatever. But and we heard that, but like there's not a lot we could do about it, and we acknowledge that, and we acknowledge that that's something we need to try and change, but we haven't been able to change this time. That's again fine, but it kind of shows that willingness to be open and honest and transparent and say, we acknowledge we have limitations still, and that encourages people to get involved again in future. Now I've just got a couple of slides left, and this is a real whistle stop sort of tour, but basically what I wanted to show you guys is that there are UK standards for patient and public involvement engagement that exist, which have been created in collaboration between a lot of like the research councils, the NHS, that kind of are a framework to give you sort of like what they classify as sort of like the best approach to patient and public involvement, and the things that you should keep in your mind when you're designing and developing and delivering things. So there are these 6 spokes that we say that you should really think about and consider and keep in mind whenever you're doing patient and public involvement and engagement. I'm not going to go through these massively because there's a lot of information on their website, and I put a link in the slide deck, so you will be able to see it when you get the slides. But what I would say is just keep these things in mind because they help you frame and design activities that are really, really sort of like considered best practice. So this idea of your communications being plain and accessible language, being well timed, keeping people in the loop, as we said, making sure that you work together in a way that values people, builds respect, creates partnerships. Making sure your opportunities are inclusive, so it's accessible, it reaches appropriate groups defined by your needs. that this idea of impact, that you're seeking improvement and sharing the difference the involvement has made to work. Making sure that if you've got opportunities to involve patients in decision making, in shaping, in governance. So it's not just simply sort of lower down, that they have the opportunity to actually influence at a higher level if possible. And making sure you support and support learning. So as I said, that's the idea of giving back to people, that it's not all take, that patients are getting something from this, that they are learning, that they have opportunities to build skills during their involvement. So that now is the end of my presentation. I'm now open for questions if you want to post them in the chat or put your hands up. There are links which are available for you to click through. Lots of interesting different websites, different perspectives on this sort of thing. And there's my email address. So thank you very much, everybody.